So we'll introduce Darcy now, who will talk about new protocol therapy with TIL.
Good morning, everyone. My name's Darcy. I'm one of the other physician assistants that works with Dr. Kirkwood and team. I have been working now for 10 years, which is really hard to believe in this job. I am the PA that will see you when you're on clinical trials, make sure you're tolerating treatment well, make sure it's safe to treat you, and help manage those side effects. So today I'm talking about one of our new trials. It's PD1 knockout TIL. So what does that mean exactly? These are just my objectives. So before I talk about what PD1 knockout means, I wanted to just do a brief overview of what is PD1. I know we hear everyone talk about PD1 inhibitors, and I feel like sometimes we throw that term around and patients don't really understand what we're talking about. So before we talk about how we're going to modify PD1, I just wanted to overview PD1. So we think about this as the brake for the immune system. So PD1 is actually a protein on our immune cells, and it binds to the PD-L1 ligand on cancer cells and normal cells and tells the T cell to leave the cancer alone. So when we give patients PD1 inhibitors, as you can see in my little graphic here, that binding, as you can see on the right, doesn't occur. And so that allows our T cells to fight those cancer cells. So what is PD1 knockout? So PD1 knockout TILs are a TIL product that has undergone genomic editing to disrupt the gene that encodes PD1. So on this graphic here, you can see exactly what Melissa just went over. We're going to have our surgical resection and isolate those TILs. And then there's an extra step involved in this trial where we actually take out the PD1 and then give the cells back. So if these T cells don't have the PD1 protein, then they can't be turned off by the cancer. A little bit more detailed graphic here. You can see on the right, again, this IOV-4001, this is actually the drug that Iovance, the name of the drug that Iovance is using. And these T cells the PD1 is inactivated on these T cells. So this gives our immune system an extra chance at fighting this cancer. So the theory behind this, and I'll go over the goals of the trial in a couple slides. But this makes the PD1 knockout TILs more effective at fighting the cancer. In mouse models, the improved anti-tumor activity was observed compared to traditional TIL. And I actually have that on a graph here as well. This is from Iovance as well. You can see this yellow line as patients without no adoptive transfer. The one I want you to pay attention to here is this red line. So the tumor volume of the knockout TILs has decreased compared to both mock TIL and mock TIL with a PD1 inhibitor given, so a systemic infusion like we do for everyone. So this is in our mouse model. This is some of the preclinical data that Dr. Najjar talked about that was the pre-research for them to develop this trial. So here at Hillman, we are doing, you might hear us throw around these numbers, 22127, but this is a study to investigate the efficacy, so how well it works, and the safety of an infusion of the IOV-4001. This trial is actually for adults with unresectable or metastatic melanoma, or stage 3 or 4 non-small cell lung cancer. So it's looking at both. I'm just going to talk about the melanoma portion of it today. Here's another great little graphic from Iovance. So looking at the study design. I was actually going to talk about differences between phase 1 and phase 2, but I took that slide out because Dr. Najjar went over all of that already for us. But our phase 1 objectives are going to be to confirm the safety of the IOV-4001 and determine the recommended phase 2 dose. Remember, that's one of the things that we look at is safety and then making sure we're at the right dose. And then our phase 2 is going to be, as Dr. Najjar said, assessing the efficacy of this drug. So for our melanoma, again, I'm just going over the melanoma slides here, but our melanoma cohort is going to have progressed during or less than 12 weeks after their last anti-PD1 or PD-L1 dose. If the patients have a BRAF mutation, they should have already received treatment with that too. So basically, we're making sure that the standard of care treatments have been exhausted and the patients are not tolerating or doing well with those. And then this can be an option for them. So our secondary objectives, remember Dr. Najjar said we look at one main question, but we also have these other questions that we want to look at. So we're going to evaluate the efficacy, the duration of response, disease control rate, progression-free survival, overall survival. We always are looking at safety and tolerability, and then just the feasibility of doing the PD1 knockout for these patients. So as Melissa just talked about, there are certain requirements that patients need to have. So for this specific trial, again, just focusing on cohort 1 for our melanoma patients, they need to have stage 3C, 3D, or 4 unresectable or metastatic melanoma that has progressed. And again, we just talked about needing the prior PD1 or prior BRAF. This trial is only open to patients greater than 18, equal to the ECOG PS. That's their performance status. So we want patients to 0 to 1 means that they're doing well. They have, they're healthy enough to tolerate these treatments, which can be difficult at times, and have a life expectancy of greater than 6 months. Again, we need to have at least one resectable lesion that has to be greater than 1.5 centimeters, so same as the standard of care dosing. And then we also have to have at least one lesion that's considered RECIST measurable. So RECIST is the objective way that we assess our patients' scans on a clinical trial. So for a solid tumor, that needs to be greater than 1 centimeter in the short axis, or if it's a lymph node, it needs to be greater than 1.5 centimeter, a solid tumor greater than 1 in the long axis, and a lymph node greater than 1.5 in the long axis. Cardiac functioning is required. Pulmonary testing may be required. Again, as Melissa said, we need to make sure that your lungs are able to tolerate any of these side effects you may have. Unfortunately, the uveal and ocular melanomas are excluded. Hopefully that's something that we can expand to in the future. Again, symptomatic untreated brain mets are excluded. If the patients have a history of brain mets that have been treated and they're stable, those patients would be allowed on. Prednisone steroid therapy, again, needs to be below the immunosuppressive dosing. Any form of primary immunodeficiency will be excluded. And then we also have no other primary malignancy within the prior 3 years. So our trial schedule is going to be very similar to the regular TIL, where we'll get our same screening, labs, the physical exam, PF pulmonary function tests if they're needed. Some patients will need eye exams, cardiac testing, and CT scans. And these give us a good baseline so that if things change, we have something to compare it to. Then we'll go into the surgical resection of the tumor. The tumor will be sent to the facility where the IOV-4001 is created. So the actual administration, again, is going to be very similar to the standard of care. We have admission to the hospital for our myelolymphodepletion, then the single infusion of IOV-4001, IL-2 administration, and then close monitoring during the admission. So I've found a little graph in our clinical trial that kind of gives you a good pictorial. So day 0 is what we call in the trial the TIL infusion. So that's when you're getting the PD1 knockout TIL. So 5 days prior to that is when we'll do the cyclophosphamide and fludarabine. That's the chemotherapies. The Mesna is another drug that we give to help protect the cystitis that can be caused from the cyclophosphamide. So during that regimen, again, you'll be in the hospital that whole time. We'll do the IOV-4001 infusion. And then same as regular TIL, we're going to be giving the IL-2 afterwards. And again, based on how well you tolerate it determines on how many doses that you will get. After discharge from the hospital, once your counts are recovered and you're feeling well, we will keep a close eye on you. This may be a little bit more intense than the other TIL schedule because there are required visits. So we'll do the physical exams, labs, imaging. The restaging scan schedule will be completed at week 6, 12, 18, and 24. And then after week 24, we go to every 12 weeks, and hopefully we'll be seeing nice, beautiful lungs like in this picture. So this is my last little picture I have in here. I know this one's a little bit more involved, but again, very similar to TIL, where we'll take the tumor in the top left, have the surgical resection, ship it to the manufacturer. They will harvest the tumor, and then we will take the PD1 off of those TIL cells and then ship it back to the patient for their infusion.
Thank you, Darcy. So this is the new protocol that's up and running, and slots for it were originally going to be few and far between. They are actually now ample. And so we are ready to enroll patients in this. We've already treated 10 on the standard of care TIL, but we'd love to do better than the 32% that was already mentioned. That's the goal. And so we enlist your involvement. Questions?